chapter, of course, is on the non-narcotic or non-opioid medications. And this includes things like aspirin or other salicylates, non-steroidal anti-inflammatory drugs, NSAIDs, okay, which you're all familiar with, acetaminophen, and then we also throw in their drugs to use gout because some of these drugs are related to that. So they're always seem to be, whatever farm book I ever look at, they all seem to be classified, always seem to be classified together. So a lot of what you read about in this chapter was familiar to you, but maybe you didn't know some of this information, right? So pain control, really, really important in dentistry. Pain is often the reason that people come into the practice, okay? And pain is sometimes the reason that keeps them away. So providing pain control for whatever their chief complaint is, as well as providing pain control for the procedures that we're going to do, are really important to us. And you're going to be, again, up against this every single day in your daily practice, okay? So you need to be able to recognize and evaluate a patient's need for pain control, as well as evaluate their background, their medical history, and all of that, so that you can properly, within the office, provide pain control and prescribe pain medication for them, okay? And it's going to be left to you. We're not primary prescribers, but it will be left to you very often to be providing the patient with the instructions about taking pain medication, okay, and also about drug interaction. You are often the person that does the medical intake, so you need to provide that information, okay? Pain is actually a good thing, which doesn't really sound right, does it? But pain is the way that our mind lets our body know, okay, or our body lets our mind know that we have a problem going on, okay? It is a protective symptom, if you will. And the inflammation which precedes the pain is our body's way of trying to get rid of an infection or as a result of injury, trying to heal itself. That inflammation is, again, another protective mechanism of the body. So if you're wondering why we're fighting with all of these chemicals and reactions that our body is having, it's because we are subjected to pain from infection and inflammation. Okay? When we feel that we're in pain, there are different components of that. There is pain perception. That's an unfortunate word in a way, because don't you think of perception as the way you feel and think about things? It's actually, perceiving something is actually a physical response within the body, okay? Reaction is the psychological component to it. So some of you have already observed your patients in pain. And I know that one person told me that their brother was in and she was probing and it was like she was cutting his arm off, okay? Or another person observed a patient who had a lot of deposit and inflammation in their mouth being debrided, and he just laid there in the chair as if, you know, nothing was happening, like they were polishing, okay? So the way that people respond psychologically to pain is extremely different, extremely different. And a good way to remember this is that the perception, think of perception by your brain, is a physiological response. So perception, physical, whereas the reaction that you have, which is the emotional response to it, if you will, is the response, okay? Perception, physical, reaction is the response that you have to it. Yes, Layla?
So the reaction, the one that varies by person by person?
It does. Whereas, yes, whereas perception, and how do we know that? In doing studies of, for people, actually they do a lot of these studies on people that aren't in pain already from something, but they subject them to a painful stimuli, and physiologically, most people respond about the same, okay? Or I should say perceive about the same. You see, those words are bad, okay? Whereas their psychological response to it is the one that varies the most, okay? And you're gonna observe this very, very frequently. Okay, and this is what we just talked about. People uniformly respond, or perceive pain. See, these words are very bad, okay? But they have a variable reaction to it. So response, reaction, perception is the physiological response. We talk about a pain threshold, okay? And that's the point at which we react to pain psychologically. So the patient's sitting in your chair and you're sitting there probing and they're going, okay? They're reacting to it. And sometimes the more that you do that, right, the more that you actually feel it. Whereas you're sitting there trying to be brave, and you're like, okay, I'm on a beach, I'm not really here, somebody's not poking at my mouth. You can sort of psych yourself out of reacting to it that way, or responding to it that way, okay? And we also know that there's a variation within the same person in terms of kind of where they're at that point, okay? Because you can raise or lower that pain threshold, okay, because of different means. We know that how we're feeling that day. You know, it's kind of like, I always think about, well, there's the morning that you get up and you have the headache or you have the cramps or whatever, and you know you have to go to school. So, you know, you take a shower, you down some coffee, you take a couple of ibuprofen, and you get out the door. Whereas you know if it's a morning, it's a Saturday morning, you don't really have anywhere to go, I'm in pain or whatever, I can sit here and, you know, snuggle or whatever. You know, you have a very different response to it that day than you do the day, you know, you just gotta get out the door and you gotta get out there and do it, right? So it's definitely raised and lowered by many different things. And I like this illustration from your book because it really talks about it. What lowers your pain threshold? Well, if you're anxious, if you haven't slept, lack of sleep is responsible for so many symptoms, for so many different diseases, for so many different things, okay? You're tired, you're angry, okay? You get in the chair, the dental chair, and you sit down and you're angry because the hygienist was late and whatever, and you sit and they poke and you're like, ow, ow, now she's hurting me in addition to all of the other things, you know, that can do it. Fear is huge. Fear is probably the one that fear of pain and then experiencing the pain. You're sitting there, you're waiting for it, right? And your response to it is going to be a lot greater than it is if you know, kind of psych yourself for it. Depression, definitely. If you're already uncomfortable and you're already in pain, and then someone subjects you to more, your response to it can be greater, okay? Your threshold has been knocked down, okay? All your defenses are down. Isolation. All of those things lower your threshold to pain and make you respond to it, okay? Those all lower them, okay? What about raising them? Well, we feel a lot different, okay, if we have a really good night's sleep, don't we? We're rested, we feel refreshed, okay? Diversion, okay? So you put the video on for your patient, or you talk to them about their grandkids, or whatever it is that you need to do. We know that when we have somebody sitting in the room in radiology, we're kind of talking to them and responding to them, and we're saying, oh, and they're, you know, you think that they're ready to gag, and you know, you tell them lift your foot, and they're thinking, why is she having me do this? And the whole time you're thinking, this idiot's making me lift my foot 6 inches. They're not gagging, okay? Diverting them, okay? Using music. Has anybody worked in an office or been to a dental office where they give you headphones, right, with music on them? It's a great idea. There are a lot of people that really are turned off by the sound of the ultrasonic or the drill, and so a lot of offices we used to keep little tapes, not that we use those anymore, but a CD player or an iPod, they'll keep that with some earphones, and that will help to divert the patient from the pain and the stimuli that's really bothering them, okay? Empathy, right? Telling your patient, it's okay, we're gonna be done with this really quickly, I'm gonna try and make you as comfortable as possible, okay? And then we pull out the big guns, okay? Then we're gonna pull out the analgesics, maybe the topical, okay? Maybe the patient's gonna pre-medicate with something to make them less anxious, okay? And we'll talk about those anti-anxiety agents that we use for those reasons. But of course, analgesics are what we're talking about today. And antidepressants, bless you. If someone is depressed and they're being treated for it, okay, and they're in a better state, they're gonna respond a whole lot differently. So when we talk about analgesia is, the definition is the relief of pain, okay? And in managing pain, we deliver better care, okay? We make our patients less anxious about treatment. So the patient comes in, they're very anxiety ridden, we do that initial appointment, we tell them everything we have to do next time. And by the way, you know, we're gonna provide such and such for pain treatment. Now, if they're afraid of needles, you might have to get them over that hump as well, okay? And if you are, you know, you have to get yourself over that hump to provide it for your patient, and you will. But they have a reasonably good experience, and they want to come back, okay? It's a vicious cycle when someone has been in pain in a dental office, and it makes them not go back to the office, and then their mouth gets into such bad shape that they're in pain again, and that's what's bringing them back to the office. We see this over and over and over and over again, okay? It's a very, very vicious cycle. We see it in public health a lot. Maybe people don't have the means to go for regular appointments, so they wait until something hurts them, and then they show up and then they have a negative experience. Or maybe they have a positive experience and then they go back, okay? In terms of the analgesic treatment that is selected for that person is an extremely individual choice, okay? It is bless you, it is very patient specific, depending on where they are in that continuum of care, where they are in their threshold of pain, what other medications they're taking, what previous experiences they've had, okay? So for one person, they may be fine going through all of their debridement and everything with absolutely no pain medication, no local anesthesia. And for another, it may demand a pre-treatment, it may demand an anesthesia, and it may demand post-treatment analgesia as well. So it's for the same procedure, okay, with the people with this, looks like the same condition in their mouth. It's amazing how much that varies. Okay, so again, we're talking about two different major drug classifications today, the non-opioids and the opioids. And the other names for these are the non-narcotic, for non-opioid, peripheral, okay, where they treat pain as peripheral, mild, or also antipyretic and analgesics. Okay, what does antipyretic mean? Against what? Fever, right, it reduces fever, okay? And many of the drugs that reduce fever are analgesics and vice versa, not all though. Opioid, we're talking about what we used to call narcotics, okay? Centrally mediated, they work centrally, okay? And they're strong analgesics, okay? And in looking at the differences they are different because their mechanism of action is almost completely different. They kind of, they meet in the middle a little bit with the control of fever, if you will. But even in the non-opioids, okay, which act primarily on the nerve endings, peripherally on the nerve endings, right where the pain is happening, okay, so that our body can't perceive it because they're working right there. If they're also antipyretic, if they also relieve fever, they actually do that centrally, okay? Whereas, in terms of the site of action, the opioids work right on the central nervous system. So it's not completely true, but you might say that the non-opioids really work on our perception and the opioids work more on our reaction or our response in general, okay? In general. So the opioids work on the central nervous system. Their mechanism of action is that the non-opioids, okay, will inhibit prostaglandin synthesis. And the first time you read that, they told you that right in the beginning of the chapter and you went, yeah, so like what does that mean, okay? Right? Because you're like, why are they telling, I don't know what prostaglandin is, I don't know why that is in any way significant. And then once it was explained to you, you're like, oh, now I get it, or we'll get it today, okay? So again, they inhibit prostaglandin synthesis at the place where the pain is taking place. We'll go through that in a little bit more detail. So they actually reduce what our brain perceives as pain because they're reducing the physiological response, okay, that our body has to it. Whereas the opioids affect the response to pain in the central nervous system, okay? So they reduce our reaction to it. You might even think about it, because if you think about the fact that these opioids, okay, are also called narcotics, and that comes from a word that means stupor. So maybe we kind of feel the pain, but we just don't care. It's not quite that simple, but really it reduces the way that we respond to it because it depresses the central nervous system, okay? It depresses that whole CNS response. So the loose classifications here are the salicylates, or the aspirin-like products, the NSAIDs, non-steroidal anti-inflammatory drugs, and acetaminophen, which is kind of in a class all by itself. The ones that I want you to know in the first class, the salicylates, are aspirin, okay, acetylsalicylic acid, or also called ASA. There are many, 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 many brands of this, of course, including generic brands as well. And but that's what you'll see most likely. And the other one is called diflusanol because it is used in dentistry, and we'll talk about that briefly. So those are the two drugs to know. And remember I told you that when we get to the specific drug classifications, I will tell you the drugs to know. Okay, so those are the two salicylates you should know about. Aspirin has been used for literally thousands of years. It was extracted from willow bark. Remember, we go back to our medicine men, okay, who made brews and teas and whatever out of everything that they found in the plant and animal world, and kind of tested it on people and saw how they responded. And it was seen very early on that if they brewed a tea from willow bark, that it would reduce pain, it would reduce fever, and later on we found that it also reduced inflammation, okay? It is an extremely useful drug. It has its negative effects too, but it's an extremely useful drug. And you'll always see other drugs, pain-relieving drugs, compared to aspirin, even those that aren't salicylates, but it is the prototype salicylate, okay? New drugs are always compared to, in terms of the potency and efficacy, they're always compared to aspirin. In terms of mechanisms of action, aspirin does it all, okay? It is analgesic, so it relieves pain. It is antipyretic, so it relieves fever. It is anti-inflammatory because of its mechanism of action, okay, and that prostaglandin synthesis. And it is also antiplatelet, meaning what?
Doesn't
I heard
allow
blood thinner.
doesn't allow coagulation.
Okay, it's actually not coagulation, it's actually platelet aggregation. But I know what you mean, okay? We'll make those distinctions. Most people think of it like blood coagulation process, bless you, or the blood coagulation cascade, which is very complex. So we'll be talking about that. So you'll see, have any of you had patients already that are taking low dose aspirin? Right? A lot of them are taking it. We'll talk about that too. We know that its effects are related, all of these effects actually, are related to its ability to inhibit prostaglandin synthesis, okay? Prostaglandins are chemicals that are put out by the body in response to inflammation and also responsible for a whole lot of other things, okay? The prostaglandins in response to inflammation are sent to the site of injury or infection, okay? And they will actually release other chemicals, one of which is bradykinin, and it's an extremely complex process. But just take my word for it that it's the prostaglandins that are responsible for that. And they release these other substances that sensitize the ends of the nerves to pain. Why? Why? Because we need to know that we're having an injury, okay? You poke yourself with something, you step on a nail, whatever it is you do, your body needs to know that it's been injured, so we are in pain from that. We have an infection, we get inflammation, we get swelling, we get all of that. There are a lot of chemicals that mediate that, and it's actually a response. You're learning about this in perio. You know, periodontal disease is an inflammatory disease because our body's being attacked by bacteria. Okay, so we respond to it. It's actually a protective response, even though it hurts and it destroys other tissue. Okay, it's very destructive. So if you inhibit the prostaglandin synthesis, you're going to inhibit the other chemicals that they mediate, and you're going to then reduce, maybe not completely limit, you reduce the amount of pain. So less prostaglandin equals less pain. So again, inflammation, a defensive reaction. Okay, we all know what goes with inflammation. Okay, the erythema, the redness, the edema, the swelling, the heat, the pain, the fever. Okay, the pyrexia as it's called. Okay, and we can't have, with enough of it, we can't have loss of function. You get enough swelling, okay, in your face, your arm, your leg, whatever it might be, and it actually reduces our ability to move without a significant amount of pain, and the swelling can actually physically reduce our ability to move. So anything that's anti-inflammatory has to mediate some of those responses. Okay, inflammatory mediators, when we talk about those, we're talking about a lot of chemicals that are involved in that process, okay? And the ones that we are most concerned about are COX-1 and COX-2, okay? Cyclooxygenase is the chemical, okay, COX-2, which converts, again, arachidonic acid into prostaglandins and leukotrienes. Again, really complex process, but we simplify this enough so that you understand it. So the COX-1 and COX-2 are responsible for this conversion. So if we reduce the prostaglandins, okay, and we reduce the amount of cyclooxygenase that is released, okay, we feel less pain. It's the prostaglandins that send the pain from the nociceptors from here. Think about getting stabbed with something, okay? It is the prostaglandins that stimulate them to feel pain, okay? Aspirins and NSAIDs both inhibit the cyclooxygenase, but they also inhibit cyclooxygenase 1, so COX-1 and COX-2. Remember when we talked about drugs and having a target, and we talked about them being what for one particular type of thing?